I stand here speaking about probably the commonest disease or commonest presentation that any orthopedic surgeon gets in his busy outpatient, which is somebody with a low back pain. And I am here to share some myths, some realities, which have made us think differently. Degenerative disc disease. Today, I am close to 58 years of age, and obviously my lower back does not look the same as it did when I was 28. However, is it something that's an aging process, or is it a pathology by itself? This is an enigma that remains unsolved. This is an MRI of a 22-year-old. Yes, none of the discs look really very healthy except probably the L3, 4. The ones above that seem to have small nodes and make us suspect a seronegative spondyloarthropathy. The ones below are dark degenerate, and we believe that this man could either be obese or a weightlifter or has abused his lower back. May I share with you that none of the above were true. He was a young executive, and he had none of the above that we suspected. This is a 60-year-old where we expect things to be far worse, but he appears to be much better preserved. Hence, we today are not too sure that we can predict chronology based on what we see on MR imaging, as I was shocked when I saw this image of a very dear friend, cancer surgeon's brother, whom I treated about a decade and a half back. He is a 26-year-old businessman when I have actually been treating him for almost 4 to 5 years non-surgically. And I recently heard an ailment called juvenile degenerative disc disease, and that's what I had christened him to be, where I found the lower 3 discs appearing so very different from the ones above. And there is some genetic basis to this, which probably we are not aware of. But this young man managed to pull, till push came to shove. He continued with his golf, he continued with his marathon running, but back pain was getting worse. And what was now unfortunate, that despite my having forced him to give up smoking 6 years earlier, he was a claudicant, he had paresthesia, left lower limb was getting a bit weaker, affecting his activities of daily living. And he shared with me at the age of 26 that, Ram, I'm getting married probably next month or maybe a couple of months later. And I am not very sure because I am now feeling that there is some dysuria, delayed as far as I'm giving, sort of having some problem with my urination, and taking me aside said that he's not too sure about his sexual function as well. Now, these were things where the red flag came in, and I said, let's have a look at you all over again. These were his plain x-rays, not very helpful. Flexion extension, no gross mobility, but you actually look at it more intently, you see that there is a calcification of the annulus at the L4-5 level, not as visible at 3-4 and 5S1. What next? Well, my guess was as good as yours. I didn't know what to do. I did a sagittal MRI, and I'm talking 15 years back. I did a SAG MRI, T1, T2 weighted images. I did axials, and I didn't know what to do next because all the 3 levels that I scanned on axial images deserved surgery. All 3 of them could explain the left-sided pain, and probably all 3 were contributing to a lesser or greater extent. I did a whole spine imaging. Is it limited only to the lower back? It was limited to the lower back. The upper part was pristine, clean, and he was younger than I was. What did we do next? Well, we did his electrophysiology to reconfirm that what I was thinking was correct. We even did what is called as a discography at that time. We went ahead and gave diagnostic root blocks, which told us that yes, all 3 were having some component. We ruled out everything else. All the HLA-B27s, anti-CCPs, RAs, all negative. Built up his vitamin D3, B12. Had my rheumatologist on board. They all said, no, this guy needs surgery. We don't have a name to the disease, but he needs surgery. Well, I had batted him for almost 6 years and was not keen on surgery. But then I did the three most important things when you do and which you need to do before you embark on any such procedure. The first is counseling. The second is counseling. And the third is counseling. You have to discuss everything threadbare. Even if this surgery may take you 2 hours, 3 hours, you actually have to spend composite 2 to 3 days time, maybe over a couple of weeks, to explain everything to this young man. And if you then embark on surgery, unlike what is happening today, we should first ask the question, why are we doing the operation? After that, we decide, how are we doing the operation? And finally, we embark on what are we going to use during the operation? Today, we started working in the opposite direction. We decide we're going to use this implant. We then decide how we are doing it by minimal access. And we very often forget, why the hell were we doing the operation at all? Hence, start with why. The why is he needed decompression. Would the decompression be only a fenestration discectomy, a laminotomy, an interlaminar discectomy, or a complete laminectomy? Well, this young man was different. He was like Sachin Tendulkar. He was an exception to all rules. I didn't know what I'm going to do. But yes, I was struggling. We had these new kids on the block, the new Watts on the block, the new, as I said, the purpose, the process, and the product, the new products on the block. We had Dinesis. I have x-rays almost till the time that he was about 40 years of age. He's happily married. He's doing everything. He's running the hospital, which has been made by his elder brother. And he's extremely happy with the way that he has progressed. But as I said, he's still 40 and we don't know the future, because a lot of these flexible rods, which you have above the solid rods, don't really remain flexible forever. They do become fusion devices over a period of time. So this is the non-fusion device that I looked at. We also had at that time, and I'm talking of 15 years back, 2008, the Charité had come in, which came in for a short period of time, the disc replacement prosthesis, and then got withdrawn because of access issues. So I had that option. I also had the option of the interspinous pressure, the D-arm, which I have not used by choice, or the Wallace ring, or many other interspinous pressors which came and went despite getting US FDA approval. What did I do? Well, I thought, should I fuse all the 3 levels? I did not. I did what I did, which is in front of you, a hybrid. This is that isobar TTL where I had a solid here and a flexible here. So I have gone solid across 5S1, flexible across 4-5, having decompressed all the levels. This is exactly what I said, 3-4 micro decompressed, 4-5 decompressed and soft stabilized, and 5S1, a T-lift, transforaminal lumbar interbody fusion. That's the immediate post-op. You can see the skin staples there. And that's 7 years post-op. I've seen him very recently, not as a patient, but just visiting some other patient in the hospital. And he was perfectly fine and grateful for what we've done. Where does this bring me to? This brings me to a situation where I'm talking of invasion in the lower back. If it's done, it should follow the principle of miracle. We have to treat the man and not the scan. Very often there are clinico-radiological mismatches. Go with the man, don't go with the scan. Howsoever dangerous the scan is looking, if the man is safe, this man is better, hold on, because the scan will follow. Please remember that the scan will follow if the man is recovering. If you do invade the body, it should be minimal invasiveness, risks and cost having a long-lasting effect. As I've said earlier, and I'm repeating this, and I say it every time when I take a talk on microlumbar decompression, is you may take 20 minutes to perform the microlumbar decompression, but you must take 2 hours to counsel the patient and the family prior to doing any microlumbar decompression. I feel it is probably the most important part of the surgery. Coming to now the overview. 80% of us will have low back pain. These are the three major components that will hit us in our lifetime. It will be either a lumbar disc herniation or a lumbar canal stenosis, two of which you've heard, and a third, which I have christened, and you can use it if you want to, called lumbar canal stenosis plus. Lumbar discs, we all know what a degenerated disc is. It looks bad radiologically, but if it's clinico-radiologically bad, it's only then that you will address it. That's my patient who I showed you. You could guess the age today because it's 26. But if I were to show this to you earlier, you would have said 45, 50, 65, 70. This is what we go through from the top, from a dysfunctional phase all the way down to an unstable phase and going to stabilization. This was actually originally described by Kirkcaldy-Willis, and we've learned that disc degeneration is going through a stage of stability to micro instability to macro instability to auto stabilization. I repeat, stability to micro instability to macro instability to auto stabilization. And if you can hand hold the patient through the micro and macro instability, a lot of them will settle without a surgery. Having said that, what actually happens and brings the patient to us? There's a tear in the annulus, there's a mechanical component and a chemical component. There's something that pops out, which is the proteoglycan from the nucleus pulposus, comes and hits the nerve, causes a leg pain or a radiculopathy. Well, when we see this MRI to the left, we start imagining that as an intraoperative picture. Yes, if you were to operate, you would get that as an intraoperative picture. And you could very proudly show it to your patient post-operatively and feel good about it. So would the patient, so would you, so would the hospital. However, if you are looking at a 45-year-old, chronic back pain, 4 days of severe right more than left leg pain, neurologically L5 grade 4 on 5. A lot of spine surgeons are very happy saying left EHL is slightly weaker. When you say that, it means you're buying the operation and you're selling it as well. And that's the time when you have to decide whether you're conserving or operating. Well, if it is your own relative, then it's grade 5/5. And if it's your patient, it becomes grade 4/5. So please remember that if it's yourself, it's 3/5, but you will never tell anybody that it's 3/5. So look at it that way, that we have to be very, very clear. 4/5 EHL, you can live the rest of your life. No problem. Even 3/5 EHL, you can live the rest of your life. There is no physical disability. So please put yourself in that position. I am making a case as to why this patient with this huge disc need not be operated. I'm sticking my neck out. You guys might say, 30 saal bahut paisa kama liya, abhi nahi karne ka. No, it's not the case. Please understand, there is enough literature and evidence to say the same. Natural history, and there are various studies which say that we have almost 75 to 100% resorption of discs like the ones that I showed you in 49%. That means almost half of them will completely disappear. 39, that is almost 40%, will recover or resorb to 3/4, which is 50 to 75%, and only 12% will remain 0 to 50%. And please understand, a nerve root is under pressure by a huge disc. Even if it gets slightly shrunk, the nerve root gets decompressed. Please understand that the MRI may look the same, but the patient is very comfortable. That's why I say, treat the man, not the scan. The scan will follow. Some more things to know. If the disc is more degenerated, the chances of it regressing are higher. The younger kids don't regress as quickly. The elderly people do. The greater the size of the herniated fragment, the greater the size of it disappearing. The non-contained discs shrink. The contained discs may not shrink. Young disc bulges do not regress. Again, posterocentral, they disappear or they don't even cause symptoms. Posterolateral may shrink. It's that foraminal disc in a constitutionally narrow canal, like the one that I showed you, that young man. Those are the ones that trouble the most. And those are the ones where you have to look at making that nerve root free. Please understand. Does radiological regression sort of correspond to clinical symptoms? I'm trying to say that, and that's exactly mentioned here. It takes much longer for radiology to follow the clinical resumption. This is comparing surgical with non-surgical. Like the disc that I showed you, that fragment which was taken out. In 1 month, after you've popped that disc out, taken it out, the surgical guys will be far happier. Can you see that? At 1 year, they'll be getting closer. At 4 years, they're very close. And at 10 years, they all are almost the same. So if you can patiently hold on to the patient, and the patient and you both don't give up, you can probably actually treat most disc herniations without cauda equina syndrome non-surgically. Please understand, this has a good prognosis. Most of them will recover in the first 3 to 6 weeks. Sensory fibers are most susceptible and they will be the last to recover. Even your surgery does not cause sensory recovery, so don't ever promise it to them. Resolution is not affected by surgery. This was mentioned in 1983 and still stands true today. What are the things where you have to be happy that this patient has only this? If a patient has a severe SLR on one side, but the SRR on the other side, cross SLR is free, this patient has a higher chance of recovery without surgery. If his spinal movement in extension gives him a sense of relief and does not reproduce the pain, there's a higher chance of recovery. If there's a large sequestration, it's very easy to sell the operation, but these guys will recover. If he gets more than 50% relief in the first 6 weeks, he has a higher chance of recovery. If he's an otherwise healthy, fit guy, non-smoker, he will have a higher chance of recovery. If there is an improvement in neurology, let's say a grade 2/5 became a 3/5 or 4/5 MRC, within the first 12 weeks, he will recover. If he's motivated, he's not coming under workman compensation, doesn't have a baggage that he's carrying, something from home. A lot of these daughter-in-law, mother-in-law issues, if they're not there, these people recover very fast. What are the poor outcomes? Positive cross SLR. Be very, very careful. Left-sided disc, right lower limb causing left-sided radicular symptoms. Again, these people have a constitutionally narrow canal and there's something more than is meeting your eye. Leg pain also produced on extension. Again, canal is narrow, canal is occupied by disc in a gross way. Subligamentous, as I'm trying to tell you, a disc which is not really extruded out but is stuck and is not coming out. No recovery at the end of 6 weeks or less than 50% recovery. Progressive deficit or a cauda equina. And as I said, psychological issues. These guys are bad candidates for surgery. Don't operate on them. Send them to your worst enemy. Am I clear? Don't touch them. Just send them away. Say, I'm not good enough for you. What's the role of bed rest? Now, this is a question which everybody asks. Sir, there is enough review to say there is no place for bed rest beyond the first 1 to 3 days to give pain relief. Please do not give them bed rest. Cochrane review on traction in low back pain. Ladies and gentlemen, there is no place for traction anymore. The only place that traction is given is where a patient is medically insured and needs to be admitted for the insurance claim. Okay, this is very clear. I'm not mixing words. Traction does not work. What is new? Well, chemonuclear lysis, which was done by chymopapine and the age group who are now 55 plus would sort of say that is no more done, but it's coming back because now a safer modality is being used. Ethanol gel is being injected. Artemin is a new drug which is being used for the same. Tenazumab, similar to denosumab, it's a monoclonal antibody, is now being considered to take care of the chemical part of the disc herniation. PRP, it's being used everywhere, so they're also thinking of using it here. Stem cells is being used everywhere, so they're thinking of using it here. And of course, something called back school. Now, back school is a big topic by itself, but this is proper education and exercise as far as your activities of daily living are concerned, need to be supervised by a physiotherapist, a psychologist, and a spine surgeon together, is what is the way to go for the future. In summary, most disc herniations will spontaneously go away. Large discs are the easiest to treat. Majority of patients will improve spontaneously in 1 to 3 months. The only indications for surgery are cauda equina, profound deficit like a foot drop acutely developing, unrelenting pain, and patient specific. There is a patient who is in too much of pain, agony, and you're seeing that there is a match and he's just not settling down. You've given him pregabalin, you've given him duloxetine, you've even tried steroids. I don't, but people do. Not settling down, and you think there's a complete match and you feel this particular patient needs surgery, only there do you go in. Don't convince yourself, let him buy the operation. Don't sell it to him. What sort of patients do we see? Well, we have all sorts of patients coming, the young, the elderly. Is a 3 Tesla mandatory for an MRI? If available, yes, but a 1.5 Tesla for the low back is as good. So please remember that. Don't necessarily always insist on a 3 Tesla MRI. Various people do various things. All of them do the same thing. They decompress the nerve root. How do they do it? Well, people put in laser light amplification by stimulated emission of radiation, automated percutaneous lumbar discectomy, chemonucleolysis, ozone. Any of you who do this, all the best. I don't. Because if a patient is responding to this, you would respond as much to my talking and taking some rest. If you still wish to do it, go ahead, enjoy yourself. In-clinic daycare surgery is where we are today. A lot of people do come in the morning, go home the same evening or the next day, depending on what their insurance claim allows. And what do? We do a microlumbar discectomy. It's an open surgery. However you may use it. You may use a McCullough retractor. You may use a Destandu tube. You may use a metric system, whatever you want to use. There's a small incision. Either it is paraspinal or midline slightly to one side. You go in and do the operation, identify the nerve root, as I've said, pick up the disc and take it home. Remember that in microlumbar decompression, it's a nerve root surgery. It's not a discectomy surgery. I repeat, it's a nerve root surgery. It's not a discectomy surgery. Your surgery initially should begin with doing a complete foraminotomy. For the last 25 years, I do my foraminotomy first, and then I pick up the disc. And I request each one of you do the same. Because there are times when you picked up the disc and there's so much of an epidural bleeding that you do not end up doing a proper foraminotomy. So before you pick up that very, very beautiful, juicy disc, which you're putting your hand on and it'll come out, do your foraminotomy. The bigger the disc you're picking up, the bigger the epidural veins that are going to come out. So do your complete foraminotomy. See that nerve root the way you wanted to see it completely. Then get your disc out. But the moment you take your disc out, then you're in a hurry to leave. You forget the foraminotomy, recurrence rates, post-operative so-called iatrogenic stenosis, nerve root adhesions, all happen because you've not done that. Fragments like this will come out. Today, we do only a bumpectomy or a fragmentectomy. We don't go into the disc and scrape it out. Like I was also taught that you must take it out like you're taking a coconut out. Take it completely out. No more done. Please don't do it. You're giving a discitis, aseptic or septic to the patient, and you're asking for another surgery, which will be fusion sooner or later. However, there are some people who have back pain and leg pain the same. 5 on 10, 5 on 10. You've counseled them that I'll take care, do a micro decompression. Nahi, doctor sahab, backache bhi bahut zyada hai, wo bhi theek karna hai. In that case, what do you do? Well, I used to do this surgery. Now this device is not available. I used to do the same microlumbar incision, but I used to do a standalone instrumented fusion, where I used to put in 2 5mm tubes and go and jack it up and put bone graft. Well, it worked very well. This is no more available, so I can't put in this standalone jack, which used to go in. It used to be called B-Twin. It was a discotech company from Israel, which got bought over by Kaifon. Kaifon got bought over by Medtronic, and they crushed the whole thing. Okay, it's no more available. One of the best implants ever made, which go in and jack it up. It was a lordotic cage. It used to come as a 5mm tube. You could put it as 7.5 by 9. When I say 7.5 by 9, it's 7.5 millimeters posterior height, 9 millimeters anterior height, 9.5, 11, 11.5, 13, 13.5, 15, 15.5, 17. These were the options available. Not available anymore. Go in, jack it up, use local bone graft from your foraminotomy and from your mesial facetectomy and a little bit of the spinous process here and there. Pack it in, add additional bone substitute if you want, and you got excellent results. And I was very happy. No more available. Sorry about it. However, in the elderly, we need to do much more of decompression. Hence, in that case, we do a standard procedure. Again, I'm taking you 20 years back when I used to use mesh cages. Roll them in from one side, push them on the other side. These are Jurgen-Harms cages, and we put 4 screws, 2 rods, put it in. We used to do a lot of interbody and posterolateral. We did 360-degree fusions. Gave it up over a period of time because I don't need to add posterolateral if I'm doing a good interbody. So hear me out again. If you're doing a good interbody, you don't have to add posterolateral. If you're not doing an interbody, you have to do a copious posterolateral fusion. When you're doing this in the elderly, if you're not doing interbody, then of course, go far lateral, put a large amount of posterolateral fusion. Moving to lumbar canal stenosis. Only decision in lumbar canal stenosis, it's more signs than symptoms. When do you operate? You operate when the patient is having cauda equina syndrome. Till that time, just push them. They will go up and down, up and down, up and down. When they have cauda equina, what do you look? You look at the central part of the canal, totally obliterated, and you look at the lateral part of the canal. Why do you do that? Because you have to decide what are you doing in the operation. When you're doing this in the operation, you have to decompress central, lateral, and far lateral. If you're doing far lateral as well, they need stabilization. Simple answer. If you're not doing anything beyond central and lateral, you don't need to stabilize. If you're doing far lateral, you need to stabilize the patient, provided he's fit, quality of bone is good enough. Otherwise, he stays in bed with a belt and prays to God that he doesn't get an instability. If he does get an instability, what happens? He goes into the next category, which I call lumbar canal stenosis plus. Degenerative listhesis, degenerative scoliosis more than 20 degrees needs interbody, less than 20 degrees may not need interbody, and a redo surgery. Why do I show this? Well, I show this because a lot of us are in our youth, when we keep seeing our patients repeatedly, we start seeing instability after a period of time. Keep looking at that, you think that things are moving. In the elderly, things don't move. Please stop imagining instabilities in the elderly. Leave them with a decom, they will all do well. Very few of them need instrumentation. Those who do are those grossly mobile degenerative listhesis, where you could go in, put in 4 screws, 2 rods. And I used to, again, use a lot of these interbody spacers, which were expandable at that time. Here is where I come. Can you see that? I put huge amount of posterolateral fusion. At 3 months, dikhta hi nahi hai posterolateral. At 6 months, it disappears. And at 1 year, it's no more there. Where the hell did it go? If I had not put the interbody, you would see it. Because I had put the interbody and the interbody fused, my posterolateral was never challenged and hence disappears. So please remember there, it's like nailing versus plating. The two don't work together. One of the principles will work. So where it's a good interbody, don't waste your time doing posterolateral. And if you're doing a good posterolateral, don't waste your time doing interbody. They don't work together. Having said that, less than 20 degrees of a degen scolio, just do a decomp and do posterolateral. It will fuse, as you've seen here. But if it's more than that, there's a lateral listhesis, there's a prolisthesis, that's the only time. Vacuum signs seen at all levels. Here, you would need to put in interbodies. Again, as I said, my favorite implant always there. I used to go in, jack them up, correct the scoli with that implant, eccentrically place my implants larger on one side, smaller on the other, and get away. Revision surgeries, again, 90% of redo surgeries of the spine, if they are microlumbar, will only need a microlumbar. And I'm repeating, it will only need a microlumbar. However, 10% of them will need instrumentation. In those few, you could get away with doing an instrumented fusion. Most first recurrences need only a re-decomp. They don't need an instrumented stabilization. Having said that, if you have created your own listhesis, this is my closest friend, cardiologist's mother-in-law. The same cardiologist put stents into my mother. So I put cages into his mother. I had no choice. But I did on day one, when he was treating my mother non-surgically without the invasion, I did a decomp. And then within 3 years, he put 5 stents into my mother and his mother-in-law had an instability. So then I said, listen, you've put in so much of titanium, I got to put some titanium. So I went in and put this titanium in that lady. And that's where she is. She ended up with a nitrogenic instability I had created. And 4 years, 5 years down the line, went and did this. Story didn't end here. She then went for an adjacent segment and an adjacent segment. Fortunately, my mother has stopped with 5 stents, but his mother-in-law is still following up with me. So as an orthopedic surgeon, this is an investment. And be careful. Okay, especially if your own friends are there, be very, very careful. He's looking for put the 6th stent in my mother, but I'm holding on. Okay. So finally, what have we learned? Symptoms should be more than signs. Only then let the patient buy the operation. If the signs are more than symptoms, then counsel them for the surgery. So only when they're getting quad equina foot drop, only then would you advise them surgery. Elderly osteoporotics, delay the surgery. Give them denosumab, give them teriparatide, give them time, build up their bone stock. Complex LCS, which I said, all these redos, colis, listhesis, buy time, don't be in a hurry. Instrumentation. In special situations, you might need fenestrated screws with cement. You might need to augment it with BMP. Have I used it? Yes, I have. Have I had good results? Reserved, comments reserved. BMP, it goes into the perineural area, can cause a lot of problems. Screws, wires, you have to at times combine sublaminar wires, hooks and screws all put together. Technology and technique, yes. Have I used the robot? Yes. Does it help? It does help. Too expensive for the present? Yes, too expensive. Minimally invasive, works well. Tertiary centers, yes, you always do these elderly patients in ICU setups. Don't do it in small nursing homes. Future, fusion versus non-fusion. I think non-fusion will take over sooner or later. Minimally invasive versus open. Minimally invasive has taken over. Instrumented versus non-instrumented. It all depends on what sort of a patient. Your own patient, Your own family, uninstrumented. Anybody else, you tend to do instrumented. So give it a thought. It's market driven. It's trade driven. Be a little careful. Gene therapy versus biologics versus metal. We're right now on metals. We are trading onto biologics. We have not yet reached gene therapy as far as low back is concerned. Final message. Tread cautiously into spine surgery. Things are changing as we talk, and what I state today may be state of the art. It will be history tomorrow and probably obsolete the day after. What we talk of 17th October 2021. Do what works best in your hands rather than be market driven or techno savvy. Always remember, begin with the purpose, then comes the process, and finally the product. If that is what you want to do, I don't know why that was done, but I saw this patient at the end of 3 months. I still don't know how it was done. So be extremely careful. You should know why you're doing the operation. Then you decide how you do it, and finally what you use for it. So be very, very careful. I'm still not sure why and what was done there and what he's working around with. God bless. I have followed this Dunning-Kruger effect all my life, and I'm reading it out. A lot of young men at the rear, please understand. Good results come from experience. Experience comes from bad results. This is a talk which I gave in 1994, which got me multiple awards, but it also got a lot of brickbats, because in that I mentioned something which one of our colleagues mentioned today when he said that he was comparing surgery to marriage. Am I correct? That's one of those gentlemen. And my topic, the first line was good results come from experience. Experience comes from bad results. And the next thing was surgery is like marriage. Everything looks good the first year. And I had a lot of trouble. Not in my marriage, that also happened, but in that academy, it was terrible. Anyway, the more you know, the less confident you are likely to be, because experts know just how much they don't know. They tend to underestimate their ability, but it's easy to be overconfident when you have only a simple idea of how things are. Try not to mistake the cautiousness of experts as a lack of understanding, not to give too much credence to lay people who appear confident but have only superficial knowledge. Bertrand Russell, and I quote, "The whole problem with the world is that fools and fanatics are so certain of themselves, yet wiser people are so full of doubts." So be doubtful, be vulnerable. You can only perform when you're scared. You cannot perform when you're overconfident. Whether it is Sachin Tendulkar, whether it is Virat Kohli, when they walk in, the fear of getting out on the first ball has to be there. It's that how we'll perform with spine surgery. Well, trauma, we've always enjoyed it. It's a battle we play with. But spine surgery, very, very careful.